Welcome to GNN10, a bite-sized podcast brought to you by the International Society of Glomerular Disease. Our hosts are nephrologists and glomerular disease experts, Dr. Kanar Javeri of Northwell Health and Hofstra University on Long Island, New York, and Dr. Koil Jain from the University of North Carolina, Chapel Hill.
Hi, everybody. Welcome to the new episode in GNN10. This is Kenar Javeri and Koil Jain bringing in NephMadness for the region genetics in 2025. We have some amazing guests. We'll let Dr. Elena Cervantes introduce everybody.
Thank you very much. I'm going to introduce first Matt Ross, who is the second year nephrology fellow at Johns Hopkins, and he was the writer for the genetics region. And we have as well Jordan Nestor, who is our content expert. She's a nephrologist at Columbia University, and she's also a specialist in genetics.
You tell us a little bit about NephMadness. Can you give our listeners what that is in a nutshell?
Absolutely. So the NephMadness is an educational initiative that was created in honor of March Madness, which is the basketball tournament. But here we really talk about nephrology. We have 8 regions, 2 subtopics, and the goal is for us to discuss about all these topics so that we can identify a winner. And the big question that we need to answer for ourselves is which of those will be the most practice changing over the next 5 years?
That's great. So one of the regions this year in NephMadness is genetics region. And the 2 topics are genetics and FSGS versus genetic counseling. So I'm a big proponent of genetic counseling, and I think it's something that everybody should be well versed with and a very important part of nephrology as we learn more about genetics in nephrology. And I know Koil doesn't really like that. She's a big proponent of genetics in FSGS. Is that correct, Koil?
I will say I 100% believe in genetic counseling. I don't think you can...
do we have a winner?
We don't have a winner yet. I do think, however, for the next 5 years, that maybe genetics and FSGS is going to be the one that is going to make a lot of difference. So that's why I support that region. But I agree genetic counseling is so important. That's why we don't know the answers yet.
Let's just have our content experts decide that for us. So I have Matt on my side and you have Jordan on your side. So I'm going to quiz Jordan a little bit about the genetics and FSGS. Can you tell us how many genetic causes do we know that are associated with FSGS?
So as of now, at least 50 plus genes have been identified to be associated with these monogenic causes, these rare genetic causes with the histopathologic finding of FSGS pattern lesions. But that's, of course, we don't really know. It's all based on what we know so far. We need histopathologic correlation. We also need an understanding of these other monogenic causes that might also have FSGS pattern lesions if we had ever biopsied them. And so really we talk about the phenotypic spectrum of diseases, and we just think that FSGS pattern lesions are just one aspect of it, not a whole disease entity, which we have categorized FSGS as based on histologic findings. Really, it's just a nonspecific lesion that we see histopathologically. And so we believe that there's probably a whole bunch of other disease entities that have that same finding.
One of the important things you quickly mentioned is pattern of injury. And I love when nephrologists say a pathology term, which is actually true. It's actually a pattern of injury and not a disease. And just for our listeners, it's your primary FSGS, you have secondary, and then you have these genetic components, but they all have a pattern of injury, which is FSGS. So it's not a true disease unless you don't know the cause. What about Alports? When do you connect those 2 together? That was something novel that we are learning about the connection of Alports and FSGS. Any thoughts on that?
Well, we see the FSGS pattern lesion in some individuals who have collagen 4A3 and 4 heterozygous variants. And the question is, do we also see it in some individuals, had they been biopsied, who have the classic Alports, collagen 4A5, Alports male, hearing loss, ocular abnormalities? I'm really open to possibilities of finding that in individuals across all types of variants, causal variants that have a kidney phenotype, that have kidney insufficiency and or proteinuria and or hematuria and or histopathologic evidence of injuries, even that FSGS pattern lesion. It was novel to find that individuals who had proteinuria and didn't have ocular findings, didn't have hearing loss, weren't males, actually ended up having these collagen 4A. And now we consider this whole spectrum of Alport associated illnesses. It's very heterozygous phenotypically and genetically. And I'd say for now, we think it's more in the collagen 4A 3 and 4 variants that are causal of disease. But I'm open to the possibility that it's in all of the collagen 4A associated genes.
I mean, is it more likely that we pick up the FSGS first, and then in the EM, you pick up the Alports, making diagnosis and management a little bit different because now it's more of a genetic variant as opposed to the FSGS might have been, chucked along as, oh, this might be from obesity or something else.
Yeah, I think ultimately if you identify someone, it's a non-specific finding. So if you went forward with biopsy before genetic testing and you found the lesion, and then all of a sudden now you want to do the molecular testing to see if there's an underlying cause for that lesion, I think it's the stress that the glomerular basement membrane is under because of a faulty protein structure, because of these mutations, these causal mutations that cause the pattern of injury. Yeah, I think the management is completely different because now you have a genetic cause, and I think the management is much more conservative. Of course, you wouldn't go down the path of immunosuppression or anything. It might be how you come across the diagnosis. First, you did a biopsy, and then that's how you identified it. And then you did the molecular testing afterwards. Or you had a suspicion based on family history and or presentation. Something in the history made you think, let's avoid the biopsy and let's go forward with the molecular testing first. And then that actually maybe prevents you from having to get the biopsy downstream. And so however you come across the diagnosis is fine, but I think knowing that it's a molecular cause of this phenotype is very informative for management because the management is much more conservative. And you know that if the renal insufficiency is progressing, that you're much more likely to refer them for transplant earlier because these hereditary causes tend to progress. And patients do quite well with a transplanted allograft.
And you probably refer them for genetic counseling too.
I was going to say you're going to send them for genetic counseling, but she said it is key that we find out what genetics and FSGS are involved because it would mean that you don't need to treat all the patients, right? So genetics and FSGS becomes really important.
That brings up a bigger question. The big elephant in the room is really APOL1 nephropathy and FSGS connection. I think with therapies on the horizon, and where do you put in, how do you counsel your patients who have that mutation, both heterozygous and homozygous? Because we're picking up a lot of these mutations when we do genetic testing now for a lot of our FSGS patients. How do you counsel them and how do you prepare them for potential future treatments?
So it's very difficult with the APOL1. I think the APOL1 is ready to be used in clinical use, the testing for the genotyping in the context of living donation, especially when you have an at-risk family member who you're potentially the donor for. So if your family member has kidney failure, where you're deciding whether or not that person is maybe too high risk for being a donor and where the donor nephrectomy might put them, that second hit of having the high-risk genotype and then undergoing a donor nephrectomy might be sufficient to then have a kidney phenotype downstream. I think that's very clear, the role of APOL1 testing clinically. Whenever we get referrals in our genetics clinic for patients who have proteinuria, maybe they have FSGS, and then you want to identify the cause at a molecular level, we always differentiate in the pretest counseling component the importance of knowing that we're looking for causal genes. That includes the collagen 4A, 3, 4, and 5 genes, for example, along with tons of other genes associated with the FSGS pattern phenotype. But then we have these risk variants, and the risk variants are not disease causal, but they're risk variants. But we don't really know what the modifying factors are, except in the context of maybe a living donor who's at risk undergoing a donor nephrectomy. And because we don't really know what the modifying factors are, genetic or environmental, it's really difficult to counsel individuals. And so in the pretest counseling, we're setting expectations for the patient that we don't really know how this information is really informing the clinician. But then we have to do a lot of work with the clinician who made the referral, who's looking to see the patient's APOL1 status, genotype status, because really the question is, then how is management going to change? If we don't know the modifying factors that can mitigate the likelihood of disease progression, how are we managing patients based on this genetic information? So I think it's very important to then help them, again, understand that this is a risk variant and we're not identifying a causal entity.
I will say that one thing that's very clear is genetics and FSGS and genetics and another disease. But I think genetic counseling and all of this is really so intermeshed or intermingled, right?
You said it.
I said it. I mean it, right? Thankfully, I don't have any ties to one end or the other. Yes, I'm supporting one region, but really they go hand in hand. There's nothing separated. And to Matt, I have a question. I have a patient in front of me. I see them in clinic and I say, you know what? I'm going to send you genetic testing. And I send this genetic testing and they run a slew of tests and I get this huge result back. And they have all these variants that say variants of uncertain significance, like VUS. And I don't know what to tell the patients. How are you counseling your patients?
So you're right. Typically, when you order these panels, let's say if you're going through a commercial outfit, a lot of the time they'll offer differing panels of different specificity in what genes you're testing. But you're right. Most of these companies will offer this big panel that essentially tests all the genes that they know are associated with kidney disease. I do counsel patients that the variants of uncertain significance are relatively common. We're still pretty early in our knowledge of genetics in terms of kidney disease. Two kind of important things. One is that variants of uncertain significance, I tell them, does not mean that you will develop kidney disease, but we will track these over time. And as more data emerges, majority of the time, I'd say they tend to be reclassified as a benign variant. And if later research down the road shows that perhaps this is a pathologic variant, typically the patient isn't informed of that.
But that causes stress for patients, right? If I was told, you know what, you have a variant and we don't know what it does and we will eventually find out, I will be stressed out for a while, which makes me think that anytime you're sending a genetic test, there should be some genetic counseling available. So do we have regulations surrounding it? Are we required to have genetic counseling whenever we're sending a genetic test?
Typically, no, there are no requirements prior to sending the tests. I will say, if you're going through a commercial outfit, most of these companies nowadays do offer genetic counseling, both for the patient or for the physician. I can say anecdotally, I've even had a case where I've had a patient and we get a positive result. And before I necessarily want to talk to the patient about the result, because it had implications for children, I was able to get on the phone with a genetic counselor pretty quickly, even without having to schedule an appointment. They were able to see me within 10 minutes. So you're right. It is a real consideration. I will say on the flip side too, you also have to keep in mind that these patients, presumably if you're ordering genetic testing, they already have kidney disease and you already aren't quite certain exactly what is causing the kidney disease for the most part. And so there's some uncertainty just with not testing as well. And those do have to be weighed back and forth. I think if it's a patient that you think is going to be really nervous about certain variants of uncertain significance, maybe that's the type of patient where maybe you order a more targeted gene panel if you think that might really cause a lot of stress for them as well.
I have a question for Jordan because Matt brought up a very good point. So if I have a case, and this happens all the time, especially now that we're ordering genetic testing for hypertension, we nephrologists see a lot of hypertensive patients too. And the kidney function is pretty close to normal, and you get a positive mutation for, say, complement factor H. Would you biopsy that patient? What type of counseling would you give that patient? Because are they at risk? Is it underlying TMA in the kidney that's causing the hypertension? Do you biopsy that patient? Do you do further counseling? What do you do from there when you have a normal kidney function, no hematuria, no proteinuria, but have a positive genetic test that is concerning? And it's a red flag that this patient will get TMA in the future.
I'd go back and I'd reassess everything, like why was it ordered, what test was ordered. And those, I personally am not a big fan of ordering those tests. Our Glomerular Center at Columbia, of course, refers us a lot. And I think a lot of it is the pretest counseling. And also speaking with our colleagues about what sort of, I think the functional assays that they offer for the complementopathies are quite useful. But I don't think, again, that the gene panel is very informative. Again, these aren't necessarily monogenic causes. Oftentimes, those are very severe cases that we see in children, maybe young adults, but usually the types we see are more complex forms, that they're not monogenic. They're more of these polygenic diseases when we see these TMAs, that I don't think that the genetic data that we're getting is necessarily that informative for the clinician. And so I'd go back and reassess everything. The most important thing, I think, is though there are no standards for offering genetic testing, it is the ordering provider's obligation to ensure informed consent. With genetic testing, unlike other tests, blood tests, urine tests, there are implications not just for individuals, but for their families potentially and for their communities. And so I think that goes back to the need to counsel the individuals, set expectations for what type of tests and what type of results we're going to potentially get with whatever testing modality we go forward with, if we go forward with testing at all. And also going back to the clinician about what sort of answers are you seeking? What's in your decision tree? Are you on the fence about biopsying the patient or not? The patient has very mild phenotype and you don't know what to do. I think a lot of it is very individualized. You can't really make a blanket suggestion. You really need to see what is it that the clinician needs from your services that you might help. And more importantly, what will they not get, right? Because a lot of time we're setting up, I'm the one with the bad news. I'm the one telling you that whatever you're ordering isn't necessarily going to be the answer you're going to get. And also to the patients, I tell the same thing. The overwhelming majority of individuals, we're just going to get a lot of noise, the VUSs, but we're not going to get something diagnostic or causal. But sometimes we do. And that's why we go through these procedures. And that's why we go through the testing. And that's why I think in your case, we should do it, right? Because of the percentage, 10 to 20% of individuals where we do find monogenic cause. But for these other diseases that are complex, that I think are much more polygenic in adults, there's some genetic tests you can do, but I don't necessarily know that it's going to guide the clinician very much. I go back to the clinician and say, what is it you need? What can I help you with? And more importantly, what are the limitations of the testing available now commercially that I can help you put into your framework so that you understand that if you want to go forward with a biopsy or maybe conservative management, serial observation, I'll be able to help you there, because the test might actually cause more trouble for you and the patient than actually get you the information you need in your clinical decision making.
If you don't need the test and you get it and you get now a positive result, what do you do with it? Or what do you follow? Let's say you decide to biopsy them. Let's say you even treat what number are you following? They have a normal kidney function, they have no hematuria, there's no proteinuria. What are you going to, what's your marker, right?
And a person with normal kidney function, biopsies are not risk-free. Again, I'm a big proponent of conservative management, serial observation, blood pressure, blood urine check biannually.
So this may be just something that I'm the only person worried about, but what are your thoughts about these commercial tests? Hundreds of thousands of people, I don't know what number, are getting the genetic testing done, and it's just sitting there. What are the regulations surrounding it? Could it be misused? Is it safe? What do you think?
Depending on where you are in the country, I think your policies and your concern for patient privacy vary. We care about those things a lot. We care about patient privacy a lot. When individuals are in our genetic testing environment for a genetic consult, there's an option to maybe go through research-based testing with a commercial clinical CLIA certified laboratory because it's sponsored, or we can just go through your insurance. I'm a big proponent of let's just go through your insurance. But a lot of patients I find, unfortunately, are like, I don't care. Even though the insurance will likely cover it, I don't care. I'll go with the sponsored testing. And so I think at least my role is to inform individuals that if you're going with sponsored testing, and I think this is a big thing to be worried about, these individuals have your genetic data and how is it going to be used? If it's going to be used for research and development, fine. But don't you think patients have a right to know that this is your information that you should fully know? And this is, I think, part of the informed consent process and the pretest counseling requirements. But I do think it's something very important because people are participating. What are the obligations of these companies, these private companies, to protect your data? And what are they going to do with it? You should know what your data is going to be informing. And you have a right, I think, to the protection of your data. And I think this is something we should stress very much in the pretest counseling portion of every session.
I wonder there's some fine print. When you sign off on these contracts, there's like such a long contract. Who's reading the entire contract? I think that's what's happening with most people.
In some institutions, they just have an opt-in or opt-out policy where people are just being biobanked in sequence. What's the downstream ramifications of this? What are patients' rights to this? And also, there's a lot of interplay between these academic institutions who are biobanking specimens and private industry and startups. And what are the obligations to the institution if a patient has a problem with that, right? And I think we have to be more considerate of the fact that patients might have a problem with this later on. And I think it's important that patients have a right to know where their data is going to go.
She keeps mentioning the word counseling multiple times. So I think we have a clear winner here. But just to piggyback on her point, you can't stop community doctors, everybody even ordering commercially available genetic testing. We get patients coming in with these reports and they tell me to interpret this as a GN specialist. And I think the education has to come at a fellowship level at this point to nephrologists in training, that there has to be counseling, there has to be something that has to be done before you order these tests. So as new generation of nephrologists get graduated, they're more informed about how to order these tests and what to do post and pre. You can't stop the madness that's already opened up, no pun intended. But I think counseling is the key to our fellows and to our patients.
So my question to Matt, one last question is, you're a fellow right now. Do you feel comfortable counseling patients?
That's a tricky word. I would say I certainly feel more comfortable now than, for example, I did last year as a first-year fellow. When I listen to Jordan talk, I don't feel as comfortable. I would say, yes, I feel comfortable enough for some kind of more common reasons for genetic testing. I think I feel comfortable enough. I'm using that word enough purposefully because realistically, as you all have pointed out, that genetics is typically, we see it in medical school, and then that's usually the last time you see it until now. This is becoming a big topic in nephrology. And so I think there's a lot of discomfort throughout all of nephrology with probably your average nephrologist now that this is becoming a bigger field. And so it's something we all have to learn, at least on a surface level.
I think there's so much room for improvement. I'm a program director and I'm thinking about how often am I teaching my fellows to actually do genetic counseling. We do teach them about the new genetic stuff that's coming out. They have these cool lectures, they see all these patients, but how much are they really learning about counseling? So I really think that there's a lot of room for improvement, a long way to go in genetic counseling. And so for the next 5 years, I still think the genetics in FSGS still plays a huge role, but I think genetic counseling is equally important, just not there yet. And it should be better than where we are. So Laurel, you are going to be the judge for this region for us. And for our listeners, this is not the actual result of what the NephMadness topic is.
It could be.
Give our result. What do you think?
Yeah, I am not on the NephMadness panel. I have no insight into what the judges have actually chosen. But as the producer of this podcast, and more importantly, a patient with genetic FSGS who has also had genetic counseling,
I think you made a really great argument for the importance of genetic counseling.
whether for FSGS or other conditions. And certainly from my own experience, I think it's so important and so complex. I was fortunate to have my own nephrologist be a real expert and pioneer in genetics. And when I talked with him about my results, I brought up the genetic counseling, and there's a shortage of trained genetic counselors who are familiar with all of the ramifications of genetics of kidney disease. We need to do more to change practice on every level, really, in the way that patients are getting information and consent, and the way that nephrologists are being trained, and also supporting genetic counselors as a profession and their integration into nephrology practice.
I think to all the program directors out there, I think what Laurel said is so important. I hope the take-home lesson from our podcast is that you think about incorporating some form of genetics training to our fellows in terms of counseling. And not everybody can be a Dr. Nestor, but at least we can be like everybody should know how to treat minimal change. If it's complicated, you send to a GN center. The same way, everybody should be able to graduate with basic genetics knowledge of nephrology and counseling. And when it's a complicated case, you pick up the phone and call Dr. Nestor. So I think that's what I'm trying to get at from the fellowship director's standpoint. I think if we can all agree on that, then I think we have made a point with this podcast.
And the option to call Jordan Nestor is absolutely on the table. Please, I get calls, I get texts, and I really enjoy seeing these cases, hearing about these cases, and I really am available to help you navigate these.
We really appreciate that. And with that, thank you so much, everybody, for listening to us on GNN 10. And this is our NephMadness episode on genetics in 2025.
Thank you.
Not wait to find out who actually wins.
This has been GN in 10 from the International Society of Glomerular Disease. You can listen and subscribe wherever podcasts are found, and tweet at us at ISGD Tweets. Thank you for joining us.
Okay. And so, Matt and Jordan, who's going to take on the FSGS response and who's going to take on the genetic counseling response?
I was thinking Matt would take both and I'd provide moral support.
Oh God, no.